Good morning, everyone, and welcome to our demonstration and presentation on the management of maternal resuscitation in a woman with septic shock, following the ESMOE protocols. Before we begin, I'd like to introduce our group. We are Group 1. I am Sister Jacobs, Midwife 1.
Good morning, everyone. I am Sister Njolo, Midwife 2.
Good morning. I am Sister Tamara Zumula, Midwife 3.
Good morning, I'm Sister Manzenge, Midwife 4.
Good morning, I'm Sister Trodisa Khani, playing at Dr. Zabon.
In this video, we will show you how to recognize septic shock, stabilize the mother, and manage her care step by step. Septic shock during pregnancy poses a significant risk for both the mother and the baby. It is characterized by systemic infection, inflammation, and circulatory collapse that can be recognized and identified as hypertension, tachycardia, pyrexia, tachypnea, including fetal distress.
Before we start, I am going to give an overview of our scenario. Miss Jane, 32-year-old, at 34 weeks pregnant, came into our hospital complaining of fever, chills, nausea, dizziness, spontaneous rupture of membranes, and decreased fetal movements.
Remember, in all obstetric emergencies, every second counts. Let's begin.
Good morning, Miss Jane. I'm Sister Jacobs.
Morning, Miss Jane. I'm Sister Njolo, Midwife.
We are the midwives here today at the hospital, and we are here to assist you with your admission. Can you tell me what brought you here today to us?
My tummy is sore, I'm feeling hot and cold, and I'm feeling dizzy. The baby didn't move since yesterday.
Okay, Miss Jane, you do look unwell. But before we begin anything else, we need to do your vital signs so that we can see what is causing you to feel so unwell. So I will start with your blood pressure. Okay, I'm just placing the thermometer under your arm quickly to check the temperature. Sister Njolo, will you record document the vital signs for me, please?
Yes, I will be recording vitals for communication.
Blood pressure 80 over 50 millimeters mercury. Patient's heart rate is fast and steady, 120 beats per minute. And her temperature is 38.9, degrees Celsius. Respiration at 30 breaths per minute.
Oh, the respiration is also fast. Okay, I recorded the vitals. Okay. Sister Jacobs, did you see that the blood pressure is 80 over 50 and the pulse is 120 beats per minute and the temperature is 38.9 degrees Celsius with a respiration of 30 beats per minute?
Okay, so those are critical vital signs because the patient is hypertensive, tachycardic, tachypnea, as well as pyrexia. Let me just check the fetal heart while you call for assistance, Sister Njolo. This looks like a potential septic shock.
Sister Mananga, Sister
Hi.
Fetal heart rate 166 beats per minute. Hi ladies, we have a potential septic shock.
Okay.
Please can we assist with the resuscitation?
I'm preparing the IVs.
The patient's airway is patent because she's able to verbalize with us. So can you please just assist me to move it into a left lateral tilt?
Okay.
Miss Jane, we're just moving it to the left side. Sorry, my dear, just to improve circulation. Okay, patient is positioned in left lateral tilt.
Can I quickly check the SATS monitor so long? The SATS is 90 in room A, so I'm quickly going to administer a rebreather mask for oxygen perfusion of the patient, 10 to 15 liters.
Okay, I'm going to put in IV line. Sister Jacobs, can you put me the second line? The 16, it must be a 16 to 18 gauge.
I will do that for you.
Two lines. Gonna use one for antibiotics and one for fluids. Ne?
Preparing second line for IV fluid.
Thank you.
IV line in.
IV
Normal
line
sideline.
in.
1 meter running.
All right,
What
morning. I'm
is
taking
the
blood.
guys?
Morning, doctor.
Morning, doctor. So patient Jane is a 32-year-old, 34 weeks pregnant, that presented now with vital signs on admission with hypertension, tachycardia, pyrexia, tachypnea, as well as fetal tachycardia with 166 beats per minute fetal heart rate. We have started oxygen, we've positioned the patient. She is getting fluid resuscitation. Sister Zangulo has drawn bloods for her. The patient is not allergic to any medication.
Okay, I will just prescribe the antibiotics, ampicillin, flagyl, and gentamicin.
All right,
Just
doctor.
to treat the infection.
Oh,
I will
okay.
prescribe now.
So I'm gonna put in the catheter so long, man.
All right,
Can I have
thank
the
you, Sister
catheter,
Manuel.
please? Sister Antolo, can you give me the gloves, please? Thank
There's
you.
the club system, Nenge.
IV antibiotics given to the patient.
Then I'm gonna put in the pipe for you. It's not so, it's just uncomfortable.
Okay, let's continue with fluids. If a blood pressure doesn't improve after 2 liters, then let's prepare for vasopressin. I will also prescribe.
Okay, doctor.
Urine is draining.
Okay, Sister Manini, can you please just check the patient's level of consciousness and the AGT, please? The blood glucose
James,
levels.
you know where you are?
Yes.
So both people react to the lights now. So she is conscious, she's just a bit confused. So I'm gonna check the glucose for her, man.
Okay, here's the machine.
Okay, here's the machine,
I will
sister.
also do ultrasound to check, to confirm the chorioamnionitis.
AGT is 5.4, which is normal.
5.4 millimole. I recorded that for communication.
So sister, can you help me please lift up the
Okay, it's up.
Okay, thank
We
you.
must also continue with the antibiotics, IV.
Okay, urine draining well.
Sex.
150 moles.
Sex is 96% with the rebreather mask.
Okay, I'm checking quickly the blood pressure there to see if there's any improvement. Repeat blood pressure, 108 over 58 millimeters mercury. So there is improvement in the blood pressure. Can we just do the sets again, please?
Okay. Recording for communication.
Can you give me also the side? Okay, record, sister.
Okay, thank you, sister.
Since it's now 99% at
It's doing better now.
It's much better.
Yes.
Much better on oxygen. Okay, so our patient is positioned, the airway is patent, she's receiving oxygen for assisted ventilation. She has been resuscitated with fluid resuscitation. She's got a catheter in situ for us to monitor her fluid status and urine output. Doctor has prescribed antibiotics and it's been given. So I think all in all, we've managed the resus very, very well. Doctor, is there anything else that you would like us to
Thank
continue
you
with?
very much, Tim. It was well done.
Okay,
Thank you,
so thank you,
Thank you,
doctor.
doctor.
So we will continue to monitor the patient for the following 2 hours, vital signs at every 50 minutes to see for improvement. Ne? However, if the mother deteriorates, doctor, what would be the plan?
Expect for delivery for fetal safety.
Okay. Thank you, everybody. Ms.
you,
Jay.
sister.
Thank you. You must rest well now, ne?
Thank you, Tim. Thank you.
Hi. So Group 1 has completed the maternal resuscitation in a woman with septic shock using the ABCDE algorithm. The group will now briefly elaborate how this algorithm was used during the resuscitation.
Let's summarize the key step of maternal resuscitation in septic shock using osmosis approach. ABCDE algorithm.
A for airway. Maintaining or ensuring that the patient's airway is open and clear is of uttermost importance. A patent airway is the first priority in any resuscitation, as any obstruction can result in hypoxia and affect both maternal and fetal outcomes. Positioning your patient in a supine position with the left lateral tilt will prevent autocabal compression by the gravid uterus. It also increases uteroplacental blood flow to the fetus and provides and improves circulation by increasing venous return and cardiac output.
B for breathing. Assess respiration rate and effort as tachypnea may indicate systemic inflammatory response or compensation for metabolic acidosis. Administer high flow oxygen, 10 to 15 liters per minute, via non-rebreather mask to ensure good oxygenation, decrease risk of hypoxia, and maintain fetal oxygenation. Remember to monitor oxygen saturation and maintain above 95% to ensure adequate tissue perfusion and reduce the risk of
C is for circulation. For a rapid intravenous access to administer fluids, give antibiotic, take bloods to increase blood pressure and decrease the pulse rate. And also it restores perfusion. Monitor in urine output, which indicate renal perfusion and fluid resuscitation effectiveness.
D for disability. Assess neurological status. Altered mental status may indicate cerebral hyperperfusion or sepsis associated with encephalopathy. Monitor blood glucose. Hypo or hyperglycemia may occur in sepsis and it affects neurological function. Manage confusion and ensure safety. Prevent injury and support airways if conscience is impaired.
For exposure, patient presented with uterine tenderness, identifying the source is critically targeted treatment. Maintain warmth to prevent hypothermia, coagulopathhy, and impaired immune response.
Yes. Hi everybody, reflection time. The team will now share a brief reflection of what we have learned.
I learned that quick recognition and teamwork can prevent maternal death. Time lost is life lost.
I realize that midwife role extends beyond care. We coordinate, lead, advocate for both mother and baby.
This simulation made me confident in managing emergencies using ESMO-E algorithms. It really saves lives.
Together we uphold the principle of saving mothers and saving babies. In conclusion, maternal resuscitation in septic shock demands urgent, structured and coordinated care. Therefore, following ESMO ensures safe outcomes for both mother and baby.
Always act fast.
Think clearly.
Work as a team.
We are midwives, saving mothers, saving babies. Yay!